everyone. شلونكم ويا الزحمة إن شاء الله. It wasn't so bad. حصلت باركات. أزمة الباركات الحين. Do you expect more students to come or can we start? I think we can start, right? All right, so I'll briefly talk about the pituitary hormones. I think you all know at this stage from your problem, from your triggers, and from previous as well problems. Whenever we talk, for example, about thyroid, we mention some pituitary hormones like TSH. We talked about cortisol. We mentioned pituitary hormones like ACTH. But you're familiar with pituitary hormones. I'm going to list them in front of you and then briefly talk about different, let's say, conditions that are related to abnormalities to the pituitary gland and how you may want to what investigations basically you might consider. How do you interpret such investigations? I'd like to start by reminding you that the pituitary is a very important gland located at the base of the brain, and it is often referred to as the master gland, a master gland, or sometimes you might hear the term maestro because it so beautifully orchestrates all the other endocrine glands and all the other metabolic functions in the body. It is composed of two lobes, the anterior lobe and the posterior lobe. The posterior lobe has two hormones. What are they? Oxytocin, antidiuretic hormone, or ADH. So oxytocin and ADH from the posterior pituitary. Everything else is in the anterior pituitary. Sometimes we refer to the pituitary hormones as some of these hormones and say tropic hormones. Tropic hormones, it means that they will leave the pituitary and produce or stimulate another endocrine gland to secrete another hormone. And I'm sure you know that many of the pituitary hormones are actually tropic hormones. For example, TSH will go to the thyroid gland to stimulate release of another hormone, which is the thyroid T3 and T4. So this is what we mean by tropic. Do not confuse it with trophic hormones, because sometimes they also use the word trophic. And I think from your experience in year one, language of medicine, you know anything with trophy or trophic, it's related to growth, meaning some of these may act as trophic hormones because they stimulate the replication of the target cell. TSH is another good example where once it binds to the thyroid gland, it will also stimulate the proliferation of thyrocytes. And that is why when you have excess TSH, you would also end up with a goiter. So it makes sense, right? So tropic, trophic, and then you have the effector hormones. And the best example would be, for example, prolactin, ADH. All these will produce immediately an effect. So they go to an organ, a target organ, produce an effect. There's no mediator. Just some terminology is really nothing too complicated here. So just to remind you of the posterior pituitary hormones, your ADH, your oxytocin, and then the rest fall under the anterior pituitary hormone. So remember, we have special cells, and many of these pituitary hormones are regulated by cells that are found where? Or by hormones or peptides or factors that are present or signals from the higher level, which is usually at the level of the hypothalamus. And many of these hormones, like for example ACTH, are secreted by special type of neurons in the, sorry, not ACTH, CRH. So they're synthesized, this corticotropin releasing hormone, by cells in the hypothalamus. They travel along the venous plexus, this special blood, the hypophyseal portal circulation, that's what I was looking for. So it travels through the hypophyseal portal circulation, and in the anterior pituitary, that hormone, that corticotropin releasing hormone, or CRH, will stimulate the anterior pituitary to release ACTH. And then ACTH will go, for example, to the target endocrine gland, which is the adrenals, and it'll stimulate release of adrenal hormones. So you have this axis. And this is for the anterior pituitary. However, most of the posterior pituitary is slightly different in that these hormones are synthesized actually in the hypothalamus and in cells that originate technically at the hypothalamus, as shown here. But they are released and stored in the posterior lobe of the pituitary. All right, so these are the hormones, and at the top row over here, you're talking about your pituitary hormones. Below it are the main target gland or organ, and then you have your effector hormones. All right, so for example, you could have ACTH released from the anterior pituitary, which will go to the adrenal, stimulate the release of cortisol. Today I won't talk about ACTH, I won't talk about this axis. I won't talk about TSH, thyroid, T3, T4 axis. I will, however, talk about growth hormone axis, LH, FSH, and gonads, even though you will have a problem where we will briefly talk about female sex hormones, male sex hormones, but because this also falls under pituitary lecture, so I will briefly, I'm not going to focus on this part, but at least LH and FSH as pituitary hormones. I'll talk a little bit about them as well. And then the third thing that I will also talk about is prolactin and what investigations we might do and how do you approach a case, for example, of excess prolactin levels. Once again, these are the factors that regulate the release of those pituitary hormones that I just described. So many of them, or if not all, almost all of them have stimulating hormone. What is the stimulating hormone for ACTH? It is the CRH from the hypothalamus. For growth hormone, it is the growth hormone releasing hormone. For LH and FSH, there is the gonadotropin releasing hormone, or GnRH, and TSH, there is the thyrotropin releasing hormone, so TRH from the hypothalamus. And then prolactin, there is no non-identified releasing or stimulating hormones, really. But there's also negative feedback mechanisms, and there are inhibitors of these pituitary hormones that are listed in front of you. Many of them are essentially through negative feedback mechanism, all right? So you stimulate the adrenals from the axis, so the adrenal axis, so you have CRH stimulates ACTH release, stimulates cortisol. That cortisol, through negative feedback mechanism, will suppress further release or synthesis of ACTH, and again, that axis basically. However, the exception here would be growth hormone. There is an inhibitor that is known as somatostatin, also from the hypothalamus. All right, so this is just a quick recap about the anterior pituitary hormones and the factors that regulate them, either positively or negatively. And now I'll start my talk. As I mentioned, today you already discussed the ACTH with Dr. Mahmoud. We previously met and we talked about the thyroid axis. Today there are three axes that I'll talk about: the growth hormone axis, the prolactin, and LH and FSH ثلاثة. بنبتدي بالgrowth hormone because I know you still did not take the lecture on growth hormone, the functions. You will have a physiology session that will delve into that in detail as well, the functions of growth hormone. But at least the very basics, I can describe them here so you can understand what investigations to order and what symptoms or signs you may expect or changes you may expect in certain conditions or disease conditions. So you have the growth hormone released from the anterior pituitary. It is regulated by factors from the hypothalamus, namely it is stimulated by growth hormone releasing hormone, inhibited by somatostatin, and it exerts its effect either directly or through the liver so either directly the growth hormone will bind to growth hormone receptor, or it'll go to the liver, and part of its function is to stimulate the liver to release what is known as IGF-1, or insulin-like growth factor 1. And collectively, the effect of growth hormone is increased protein synthesis, increased lipolysis, increased hepatic glucose production, and growth, essentially. And of course, there's decrease in glucose uptake because that is essentially its effect on glucose. Overall, yes, it does promote increase in gluconeogenesis, decrease in uptake, and so on. And remember, growth hormone means it promotes growth of muscles, all right? And even though it has these metabolic effects, I do want you to know that the insulin-like growth factor is called insulin-like for a reason, because in that sense, its effect on glucose is the opposite compared to growth hormone itself. It does act as insulin, mainly or namely meaning that it will increase the uptake of glucose into cells. All right? Then you might ask me, why is growth hormone that increases lipolysis, increases gluconeogenesis, and decreases glucose uptake, why is it producing a factor that is doing the opposite to glucose uptake? It is increasing glucose uptake. Well, think of this factor, this insulin-like growth factor, as predominantly affecting mesenchymal-derived cells. So really your muscles. You want the muscles to grow. And for the muscles to grow, you need to take up glucose. So I hope having that in mind helps you understand that there's no contradiction here. So far, so good? Okay. All right. راجعنا الأكسس تكلمنا عنه. We know now what factors regulate growth hormone. Once again, you'll take this in more detail in physiology, but you now know enough to be able to interpret what could happen to this axis. Two things. Either there's excess growth hormone or there's less growth hormone, so there's deficiency. If there is growth hormone excess, depending on the age of the patient, if they reached maturity or not, they will either have a condition known as gigantism, so this is typically seen in children, or acromegaly, which is what you would see in an adult. So an adult where the growth plates have been fused, they've already reached their mature adult height, etc. So these, they can't grow in height, they're not going to be giants, but they will essentially have acromegaly, where there are certain facial features that will change, their hand size might change, their tongue that undergoes changes. There's also hypertrophy, not just to the lung, but to the heart that could happen, so they could have cardiac manifestations, among other things as well. And increase growth hormone or excess growth hormone, they could also have reduced insulin sensitivity, so there's some degree of insulin resistance. And so that makes sense because we said that growth hormone also, it increases gluconeogenesis and decreases uptake of glucose. And then, those are the two conditions. How do I approach this case? I suspect this in a patient who comes to me in the clinic, and I'm suspecting this patient might have excess growth hormone. How would I suspect it? If it is a child and this is as part of a wellness visit and I'm plotting the growth chart, I might see a jump in both height. A jump is fine, but I'm talking about excessive, like multiple visits, كل مرة, it goes up, and as if there is a spurt kind of, but consistently up where it would go significantly above, multiple standard deviations above the normal range. Then I should suspect this condition in the child. And especially if you have a child who's very tall, you've made the plot and it's going way above the average. And I see the parents, they're short, مثلا, or they're very average or maybe below average. That also will make you raise the suspicion. In adults, it's more subtle. They might say, I noticed changes in my shoe size, my gloves if they wear glove size, facial features, but it could take many years until they're diagnosed. Nonetheless, if you suspect it, the simple thing to do is to simply look at growth hormone levels. But remember, growth hormone levels in adults, it is very, very minimal, and it might not be as helpful. So you could do it, but it might not be your first choice. So you could have fasting levels, and if they are detectable, and you expect in an adult that it will be minimal or near non-detectable, then that would kind of raise the suspicion that ممكن يكون there's growth hormone excess. But to make it easier, we can also just simply look at serum insulin-like growth factor, IGF-1, or also known as somatomedin C. So this has a longer half-life. It is more stable in the blood. It doesn't undergo fluctuations. In growth hormone, it undergoes fluctuations. The levels are not always the same, even during the day. All right, so you may see more during nighttime, etc., and it has a shorter half-life. So to more accurately assess growth hormone status, you could do serum somatomedin levels or IGF-1 levels. Okay, عشان أتأكد مثل ما you took in ACTH, did you take any, in the Cushing and Addison, you took some functional tests or dynamic tests. When we say dynamic or functional biochemical tests, it means that I either do a stimulation test or a suppression test. And the rule is simple. If you are suspecting excess, I want to do a suppression test. If I see a deficiency, I want to do a stimulation test. Hello? Because in this case, I have growth hormone excess. So what will I do? The natural thing is I'm trying to suppress. So there are a number of ways in which we can achieve that. Insulin is known to suppress growth hormone. Not insulin. Glucose is known to increase the levels, decrease and suppress levels of growth hormone. So I can do simply a glucose load test, much like, very similar somewhat to the OGTT test that you do in pregnancy, where you give them this like 50 grams or 100 grams of glucose syrup, and then you measure the levels of glucose in the blood, right? So this is similar, but what we will do, you give them and then you measure growth hormone levels. Glucose, food in general, the nutritional status will typically suppress growth hormone. If there's a lot of glucose in the body, this will signal to this growth hormone axis that you need to suppress. Okay? Relax. When you're hungry, when you're fasting, glucose levels are low, such as if you give someone insulin, that could actually cause a drop in glucose and can stimulate growth hormone. That is why ghrelin as well, the hunger hormone, is also known to stimulate, if you saw my slide, the levels of growth hormone or the secretion of growth hormone. So you do a glucose load, and if there is no suppression of growth hormone or very minimal suppression, less than you would expect, then this also confirms that there is excess growth hormone levels. All right? So to recap, I can do growth hormone levels. I can and see if they're in fasting levels and see if they're high. But even better, I can do insulin-like growth factor levels because they're more stable, they do not fluctuate throughout the day, and they have a longer half-life. And then to confirm that there is excess, I'll do my functional test, and in this case, I'll do a suppression test. I want to suppress the growth hormone, and the way I achieve this is by increasing glucose in the blood through this glucose load test. So many ways in which we can assess growth hormone excess. So the opposite is true. The opposite as well can be somewhat applied for deficiency. If you suspect growth hormone deficiency, which may not be really symptomatic in adults, but typically in children, this can cause a lot of problems. They can fail to grow and they can have short stature, dwarfism, and among other problems in bone growth, bone density. They would have obesity, among other things. And so same thing, you can do serum IGF-1, or you can look at growth hormone levels. But if you're going to see growth hormone levels, make sure that you take multiple samples and maybe you can pool the results together. Like I said, because growth hormone, it fluctuates and it is less reliable in a sense, but we can increase the reliability by taking a pooled sample, by taking multiple blood samples. But you can understand that this could be inconvenient, so you can replace this with serum IGF to assess if there is really deficiency or not. And هناك قلنا when there is excess, I want to suppress, and I suppress by giving glucose. So I do a glucose load test. Here, there is deficiency. If there is deficiency, I want to try and stimulate growth hormone release. شنو عكس الجلوكوز load? Insulin. So one way you can do is insulin. There's also levodopa, and there's arginine as well. All these three things can stimulate release of growth hormone. To the best of my knowledge, arginine is used more, but you have to confirm with clinicians. You can imagine that there are complications as well from rapid hypoglycemia, especially in children. You don't want to induce another complication. So this potentially could be less favorable, but all these are ways in which you can stimulate growth hormone release. If there is no response, then this indicates that there is a lesion in the pituitary or the hypothalamus, but could not differentiate between them. So it just confirms that for some reason the pituitary is not releasing growth hormone, whether because there is a lot of somatostatin or not enough growth hormone releasing hormone, or whether there's a problem with the pituitary. It does not really differentiate between those two conditions. And then just to let you know that there are non-pituitary factors that could impair growth hormone response, and this is listed in front of you. And I'm not going to go through this list because in endocrinology you will see if you have one axis that is disrupted, more often than not it can disrupt other endocrine functions. And that is why in many cases sometimes if a child comes and they see that they have deficiency in growth hormone, they will go and do the stimulation test. And if it confirms it, more often than not, they will try and look at other pituitary hormones as well. They're not just going to stop there. They're going to look at LH, FSH. Why? Because if there's a problem with the pituitary and it's not releasing growth hormone, it might not be releasing LH, FSH. There might be delay in puberty, and there might be other things as well. So they typically would investigate other pituitary hormones as well. But for me, I think it would be enough if you can just know that what test to do if you suspect excess, what test to do if you suspect deficiency. And these are some of the clinical features that you may encounter in a patient with growth hormone deficiency or a child with growth hormone deficiency. So this includes reduced bone mineral density, and with that you could have increased risk of fractures, obesity, increased insulin sensitivity. Increase? Okay, with deficiency. All right. And among others, of course, emotional disturbance, reduced exercise capacity, impaired cardiac functions, and so on. All right. So this is basically how you would investigate growth hormone excess or deficiency, more or less straightforward. Just remember the concept of when do we do stimulation tests, when do we do suppression tests. And in the case of growth hormone, these tests do exist, so you need to know which test is which. So the load test, the glucose load for excess, and the others, which is the insulin, levodopa, and arginine, is to stimulate. So it's a stimulation test. Okay, the most common prolactin problem, or one, it could either be elevated or reduced. If it is reduced, it could be that there's decreased prolactin. It could be that the patient is on some kind of medications that are known to decrease prolactin levels, and these do exist. Or it could be that the patient is having hypopituitarism. There's something called pan-hypopituitarism. Sometimes they may present with low prolactin, low growth hormone, low LH, FSH, erectile dysfunction, etc. All these things, they can occur together in cases of hypopituitarism. But sometimes there is pituitary excess. So I need to think, what could it be? What could be the reason? It could be a problem with the pituitary. It is not uncommon to have a prolactinoma, so a benign growth in prolactin or proliferation, prolactin secreting cells within the pituitary. There could be some hypothalamic lesions that will, remember how we said that dopamine can inhibit secretion of prolactin. So if you have some lesions in the hypothalamus, that may interfere with the inhibition mediated by dopamine. So this can cause increase in prolactin levels. There are other endocrine diseases like hypothyroidism, polycystic ovarian syndrome that can cause as well hyperprolactinoma. Sometimes it may be seen in patients with anorexia nervosa and renal disease, among others. But also bear in mind that there are normal physiological conditions associated with high levels of prolactin. Pregnancy. Pregnant women have higher levels of prolactin because pregnant women are preparing to synthesize milk. And in fact, towards the end of the pregnancy, many women can start producing milk. And so it's even before the baby arrives, or it is possible to have leaking of milk because there is prolactin that is being produced, and that is higher in these women. And of course, lactation. That is, we know, I think you're aware of some of the functions of, or the primary role of prolactin. That would be synthesis of milk. So in lactation, you expect there to be higher levels of prolactin. All right? So think of the normal physiological conditions in addition to other conditions that may cause high prolactin levels. And I believe in your problem, there was, if I'm not mistaken, it was a craniopharyngioma, which was pressing on the stalk of the pituitary. So that connection between the hypothalamus and the pituitary, it's kind of blocked. So there is hypopituitarism because the releasing hormones, they cannot reach the pituitary. But if you think of it, dopamine is no longer able to inhibit prolactin release, right? So the loss of inhibition due to this compression on the stalk of the pituitary may contribute, in this case, to hyperprolactinoma. How may one present if there is excess prolactin levels? In women in particular, it could be galactorrhea. In men, there could be gynecomastia. So gynecomastia, it's a condition where there's breast-like tissue in male. And it's not just, I'm not talking fat tissue because of obesity, I'm talking about breast-like tissue in males. So this is known as gynecomastia. So they may present with gynecomastia. Women, non-pregnant, non-lactating, may suddenly start producing milk, and that is known as galactorrhea. They may have, there's hypogonadism. So prolactin is known to inhibit GnRH, so it will inhibit LH and FSH. So with that, if it's a female, there will be amenorrhea, there will be decreased fertility. In male, erectile dysfunction because of this effect of prolactin on GnRH, all right? And that makes sense. That is why women who are exclusively breastfeeding their child have high levels of prolactin. In many cases, this can act as a contraception, right? You know this, انتوا حنير 3 medical students. تعرفون ان احنا ممكن ان انتوا تنصحون مثلا المرأة إذا أنت تأخذين رضاعة طبيعية, it's kind of natural contraception. طبعا الsuccess rate مالها ممكن تكون not 100% obviously. That is why if they really don't want to have a child, you need to add another mode of contraception as well, not just depending on exclusive breastfeeding. But in a nutshell, what I'm trying to say is that is why exclusive breastfeeding, there's a lot of prolactin. Prolactin inhibits GnRH, which will inhibit this access. LH and FSH will inhibit basically ovulation. Make sense? Okay. So in addition, I mentioned the erectile dysfunction, amenorrhea, hypogonadism, there's decreased libido, and obviously if you suppress that axis, if there's no ovulation in women, for example, then there is no fertility. And depending on the cause, you could have as well headache and visual disturbances, especially if it's a tumor. It can cause pressure-like feeling in the head and headache, basically. If there is a tumor that is pressing on the optic chiasm, that can cause visual disturbances. If it's the optic chiasm, you will have, what do they call it? Bilateral temporal hemianopia. So they cannot see the periphery, only the central vision. How do I approach a case of hyperprolactinoma? First of all, I'll look at prolactin levels, and then I'll determine that it's high. I'll ask a few questions because there are a list of differentials. I just need to know what are basically the possible causes. Sometimes you need to know if it's if macroprolactin needs to be excluded. What does that mean? If I look at prolactin levels, sometimes it is high, but a lot of this prolactin may be bound with an antigen, forming kind of like an antigen antibody. Sorry, they're bound to an antibody, creating kind of like an antigen antibody complex. And under normal condition, very little of our prolactin is bound to this antibody. I believe it's IgG. But in some cases, for some conditions, they may have a lot of prolactin bound to it. So these cases, typically, they may have high levels of prolactin, but most of it, it's in the a lot of it is in the macroprolactin form, which is not as active. It would not produce really any symptoms. So if you see a patient who does not really have symptoms of hyperprolactinemia, prolactin levels are high, you may want to think of that macroprolactin thing. But just to simplify it, let's say you saw that there's high levels of prolactin. Ask yourself this: is medication a cause? If it is, depending on the medication, after consulting the treating physician, you may, and depending on the symptoms that the patient is having, let's say they're trying to have a child and it's affecting the fertility. So if you consult with the physician and they give you the okay to go ahead and discontinue, you can do that, and then you can look at the prolactin. If it normalizes, then you see, you can evaluate whether they need this medicine, should they stop it to get pregnant and then restart it, and then you can evaluate it with the treating physician, with the patient as well. If it remains high, it means you excluded that the medication thing. All right, so you may investigate other possible causes of hyperprolactinoma. نفرض it's easy. سألت المريض, you ask the patient, do you take any medications? And they said no. Then you need to ask the history. You take the past history or the medical history. Do you have hypothyroidism? Are you known to have any renal disease? So there are some conditions that can cause high levels of prolactin, including pregnancy, lactation, PCOS, and anorexia nervosa. And then the next step really, باختصار, if there is high levels in some of these conditions, like PCOS, you might have high levels of prolactin, but it might not be as high. But usually if the levels are above 1,200 milliunits per liter, most of the time that high level of prolactin, usually it indicates, unless the person is, like I said, is lactating, it usually indicates some kind of pituitary adenoma. So it might be a tumor that is releasing and secreting this prolactin. It's a possibility. Either way, the best logical step would be to refer them to endocrinologist, and then they can do MRI or CT, look at the pituitary, check for any abnormal growths, and so on. And then they could basically treat them accordingly. And there are treatments, medical treatments for hyperprolactinoma as well. That's easy, more or less. You just, if you can just know the conditions that can cause increase prolactin levels, put them in the back of your head. I do expect you to know them, all right? So you need to exclude these causes of hyperprolactinoma, and then you will know how to basically take next steps, what steps to take next, all right? And also the other thing, maybe take-home message, is usually typically levels that are too high, like above 1,200, they usually indicate, or you should think of the possibility of this being a prolactinoma or a prolactin secreting adenoma. All right, خلصت شيء الحين. I finished the growth hormone story. I finished the prolactin story. It's pretty easy how to interpret these, right? And how to approach and how to, yeah. the last thing I'd like to talk about LH and FSH, all right? But I also want to briefly, I'm not going to go into physiology, but I do want to remind you that in females, LH and FSH levels vary throughout the month, throughout the menstrual cycle. So the levels of LH and FSH are shown at the top panel. So as you can see, they start, LH and FSH, at very basal levels in the first 14 days, also known as the follicular phase of the cycle. So if this is day 1 period, this is day 14, let's say around ovulation. So what happens during ovulation? There's a small peak in FSH and a large peak in LH. That large peak in LH especially is what drives ovulation. And with that as well, you will see a corresponding elevation in estrogen levels in females around ovulation. In fact, the estrogen increase slightly precedes the LH surge. And in the second half, so let's say ovulation occurred here and no pregnancy occurred or no fertilization occurred, LH and FSH will go down and estrogen will go up, progesterone will go up, but after some time when the corpus luteum realizes there's no sperm, fertilization did not take place, it'll regress, and once it regresses, the progesterone levels will drop. And when they drop, the next cycle will come, and so on. You'll take this in great detail in physiology. I'm not going to ask you any physiology, but we're going to look at how to interpret LH and FSH. So if a female patient comes to you, you can't tell the patient روحي سوي LH FSH ويجيبي لي تحاليل وبس. You need to make sure that the patient knows when they took the blood, what day of the cycle was it, because they have different reference ranges. When it's the follicular, it's different. When it's during ovulation, it is different than if it's in the luteal phase. All right, and this applies to estrogen, progesterone, LH, and FSH. High take-home message. If I wanted to design a test that will detect ovulation, this test should be able to identify or detect which hormone from those that are here? LH. Excellent. So that is why many of the store-bought ovulation tests, these are urine tests, they detect the LH surge, and they can tell the woman, yes, you're ovulating, and that increases the chances of getting pregnant, because then especially in women, if their cycle is not regular and they don't know when they're ovulating, this will give them clue, then they can start trying to have a child. Of course, I showed you this, and remember how I said progesterone, if there's no pregnancy, it drops in the luteal phase towards the end, and then you will have the next menstrual cycle. But if pregnancy did occur, you will have a new hormone known as the beta HCG towards the end. And this is what basically home pregnancy tests will detect. They will detect levels of beta HCG, which will only be produced once fertilization took place. Okay, once fertilization took place. And it should be, remember, it's going to start very low, so I don't know what is, depending on the kit, how low can it detect, but typically once a woman misses her period, she could do this test, and it should be very accurate and reliable. All right, so this is the hypothalamic pituitary ovarian axis. So GnRH is from the hypothalamus, stimulates the release of LH and FSH, which goes to the target, either the ovaries in females or the gonads or the testes in males, and it will produce the androgens. And in females, especially the granulosa test, because these granulosa cells in the ovaries, they express a special enzyme known as aromatase, so they can convert androgens into estrogens as well. We'll talk a little bit about female hormone synthesis. in problem 7, I think. And you will come to realize that estrogens are really, the pathway is common. Just like the cortisol you saw in aldosterone, they all have a common pathway. The same thing can also form androgens, and from androgens, under the action of aromatase, you can get estrogens. All right, so how do we interpret? Why am I talking about LH and FSH? Because this will help you understanding the physiology, the changes, the effects will help you understand and interpret lab results. In males, if you look at LH, FSH, testosterone, it is more or less, so you will look at these values, you will compare them to the reference range, and they should be within the reference range, so you know that this male has a normal, healthy axis. And the other thing I want to say is that elderly males typically have low normal testosterone, LH, and FSH. Yeah, normal, yeah, on the lower side. But they will not have, like women, you know, menopause and low levels of LH and FSH. This is typically seen in severe illnesses. A lot of these severe illnesses that we talked about, non-thyroidal illnesses or etc., a lot of them can suppress the hypothalamus and can have a lot of effects on different, many of these axes. So this includes this axis as well. All right, so you want to have normal testosterone, LH, FSH levels. For females, LH, FSH, estrogens, they vary based on what part of the cycle, but you can look at it and you can see if everything is within normal range, then it's fine. If you see something suspicious, then it might help you diagnose whatever it is that they're coming with. It could be infertility, for example, or amenorrhea, or period irregularities. So persistent low LH and FSH and estrogens could signify gonadotropin deficiency if you exclude, obviously, oral contraceptives. So if you have low LH and FSH, a lot of these oral contraceptives, that's what they do. They eventually suppress the axis because you're getting estrogens and progesterones exogenously, and they could act as negative inhibitors through negative feedback on the axis, right, at the hypothalamic level. So there's no GnRH, there's no LH, there's no FSH, then there is no, we need the surge for ovulation to occur. And if you take these, you will not have those normal fluctuations. You will not have that LH surge. If you don't have the LH surge, there will not be ovulation. All right? And, you know, stress, illness, low BMI can always affect. That is why if women, they're not eating very well, either, or anorexic, or have eating disorders, or they're under a lot of stress, they could have disruptions in their period. It is very common. It is reflected on that. A severe exercise, for example. Just remember that in women, just like women during different phases of the menstrual cycle, they will have different reference range for these hormones. Also, women after menopause, they will have different reference range. They typically have low estrogen and higher levels of LH and FSH. Okay, so this is expected in menopausal women. And of course, if there is a menopausal woman without elevation of LH and FSH, you should suspect gonadotropin deficiency. Growth hormone, we already talked about it. Osmolality, serum and urine, I'll talk about it later. There is a fourth thing that I forgot actually, that I want to discuss with you very briefly. It's just the water deprivation test that we do for diabetes insipidus. So this is to assess ADH. I forgot about that. All right, this is what I said. If you see, look at the males. Males have one reference range for LH, FSH, estrogens, and testosterone, and that's it. You look at this, and you'll see if the male has a healthy hypothalamic pituitary gonadal axis or not. In females, early follicular, you have different ranges than mid-cycle, which is ovulation, and they will have different range for luteal, and there are different ranges for post-menopausal women. So it's really important when you assess, when you look for these hormones, that you are really aware whether a woman is menopausal or premenopausal, and if she is menstruating woman, at which part of the cycle is the blood collected. For example, levels as high, estrogens could be as high as 1,000 in the mid-cycle around ovulation, right? And LH could reach 90 or 80, whereas under other conditions, it could be somewhere like between 2 and 9. In the luteal phase, between 2 and 9. But during ovulation, LH can be 80, 70, 85, very high. So we need to be aware of these changes. And finally, postmenopausal women, you expect low estrogens than normal and higher levels if you compare it to here, to an FSH and LH. Make sense so far? I'm not gonna, I don't expect you to memorize. For me, I would never ask you to memorize reference ranges, definitely not reference ranges like this. But for me, it's just the principle that matters. آخر شيء water deprivation test. معليش طولت شوي عليكم. I talked about growth hormone excess and deficiency. I talked about prolactin. Number 3, I talked about the LH and FSH levels, how they're different in different parts, phases of the menstrual cycle, in menopausal versus menstruating women, as well in male versus female. آخر شيء رقم 4, I want to talk about the water deprivation test. If you deprive the patient from water, you tell them don't drink water for 8 hours, come to me, I'll do some tests. And when they do this water deprivation test, they go to you. A normal person should have high concentration of urine, because the body, when you're dehydrated, when you're not drinking water, this will signal that, okay, I need to retain and reabsorb more water from the kidneys. I don't want to lose water. I didn't have a drink in a long time, so ADH kicks in. I don't want there to be dehydration, so then there will be water reabsorption, increase in water reabsorption in the kidneys. And what will be the effect of that? If there is increase in water reabsorption, to maintain your serum osmolarity, to prevent dehydration, to make sure your blood pressure is intact. As a response to that, as an effect, you will have higher concentration or osmolality of urine. So it makes sense, all of us, if we don't drink water, you'll have darker urine. صح ولا لا? And so this would be a normal person. And even if you give them synthetic ADH or vasopressin, synthetic vasopressin, that won't change the urine concentration. It'll be highly concentrated with this injection or without it, because they're normal. However, let's say you do the water deprivation test and the urine fails to become concentrated, and it appears as having low osmolality, low concentration, low osmolality. Then you suspect this patient did not drink water, and despite being dehydrated, the urine color is still very faint and it's not concentrated. There may be, or I could diagnose it with diabetes insipidus. But now the question is, I don't know whether I have diabetes insipidus because there is no ADH, therefore I cannot concentrate the urine? Or is it that I have ADH, but the receptor is not working, and therefore ADH cannot work because there's a mutation maybe in the receptor that's just not binding to it? How do I differentiate between those two conditions? Because both of them will present with low osmolality of the urine. How I can differentiate is by administering synthetic ADH after the water deprivation and after seeing that urine osmolality is low. What I do, I inject ADH and then I reassess after some time. If it normalizes, it becomes concentrated, then I know that this patient has central diabetes insipidus. Central معناتها it is just not producing enough ADH. And when I gave them this ADH, it started concentrating urine normally. If I gave them ADH and it did not work, the urine is still dilute, this will tell me that, okay, there's a problem in the kidneys, a problem in the receptors expressed in the kidneys. They are not responding to ADH, whether produced by the patient or the one that I am injecting. So it remains low. So this is how you differentiate between Central versus nephrogenic diabetes insipidus. All right, take a pause, take a breath. خلصنا. I like to have these exercises. I go through them with the students. I just to see if what did you retain, what did you learn, and to help basically the information to kind of settle in your brain. So a 22-year-old secretary presented to her doctor complaining of white milk-like discharge from the nipple. What did we call this condition? Galactorrhea. All right, for a month. She is also experiencing menstrual irregularities, had not had a period for 6 months. And when you looked at plasma prolactin levels, it showed 1,846, and then a second sample, 1,240. I guess they pulled it here. The patient was not on any medication, had normal secondary sexual characteristics. Her visual field were normal. Why did they look at the visual field? Prolactinomas sometimes can cause visual disturbances, sometimes can cause headache. Why did they look for normal secondary sexual characteristics? Hypogonadism, yes. If it's primary hypogonadism, maybe the woman will not develop these sexual characteristics, and especially in younger women as well. All right. What do you think of LH? All right. Why is LH low? Because of what? Suppression of GnRH. So prolactin typically suppresses GnRH, which could suppress LH, and this will cause basically the infertility that comes with hyperprolactinoma and menstrual irregularities, as well as in male, the erectile dysfunction and the decreased libido. All right, everything else seems to be normal. Let's look at the questions. Why was her thyroid status investigated? Which thyroid status causes high levels of prolactin? Hypothyroidism is known to cause increased prolactin levels. What are the main complaints related to the prolactin levels? Her main complaint was the galactorrhea. You mentioned this. And also the amenorrhea, and you told me that it was due to the suppression of the GnRH, LH, FSH axis. What is the likely cause? If it's above 1200 قلنا, above 1200 or 1200, usually it's a bit significantly high, so it makes me think of more towards prolactinoma. How can I confirm this diagnosis? Yeah, CT, MRI scan would work. A 17-year-old girl has dark hair on her face, menstrual period has always been irregular, and by the way, sorry, سامحوني, إذا ياتكم patient female, you may want to think of the possibility, with amenorrhea especially, and galactorrhea. Also, you may want to tell the patient, is it okay? I don't know about Bahrain, but outside they have to take consent. But is it okay if I do a pregnancy test? So you can also do a pregnancy test, just to make sure, right? All right. So 17-year-old girl, she has dark hair growing on her face, she has menstrual irregularities, especially she did not have a period over the past 4 months. She's slightly overweight, there's a lot of dark hair in her abdomen, upper lip, arms and legs. She was confirmed to be non-pregnant. They did the following tests. And لحظة هني حاطين reference ranges are for early follicular phase where relevant. فشو تشوفون هني؟ prolactin ايش فيه؟ في condition أنا قلت لكم شوي ممكن يزيد prolactin levels, but not as high as 1200 and above. PCOS, right? So keep that in mind. Slightly high levels of prolactin, dark hair, central obesity. Think of polycystic ovarian syndrome. بعد شنو ممكن يكون وياهم شيء عادة؟ أيوة يصير عندهم diabetes صح عندهم insulin resistance عشان كذي a lot of times we give patients with PCOS metformin. Okay? LH is high, FSH is low. So this discrepancy in LH and FSH is also something known to be seen in PCOS. They say there's an altered LH-FSH ratio. And typically, if you look at the reference range, FSH 15 maximum والLH 9 صح؟ معناته ان typically FSH أعلى من LH. Do you agree؟ بس هني صار عندها LH أعلى. there is العكس قاعد يصير. So this is what we mean by altered ratio. So it is outside the reference range, but LH usually is higher than FSH, whereas usually women have FSH that is إذا بتاخذون الراتيو FSH شوي أعلى من LH. That switch in the ratio also can indicate that there is PCOS. Estrogen levels are normal. What about testosterone? Right? So testosterone is slightly high. And there's something called the free androgen index. What do you think this is? I'm looking at the free androgen, or am I looking at the androgen bound to the sex hormone binding globulin? I'm looking at the free. So this is a way in which you can see the active, free, the unbound form of testosterone. So it's very high. And androstenedione as well is high. All these are precursors for androgens, and we will talk about them as well. They will come up when I talk about the synthesis of female sex hormones in next week's problem. All right, everything else is fine. Okay, let's go over the questions. What are the main biochemical abnormalities? قلنا إن هي عندها high prolactin, شوية كان high, which can be seen in patients with PCOS. Elevated LH but low FSH. All right, and elevated testosterone and androstenedione. All right. What is the relationship between testosterone, sex hormone binding globulin, and the free androgen index? ليش سويت هاي الأشياء كلها؟ قلنا إن I want to assess basically the active androgens, the ones that are free, the ones that are unbound to this sex hormone binding globulin. Testosterone binds albumin, sex hormone binding globulin, resulting in very low free testosterone. So the free androgen index is the ratio of total over the levels of sex hormone binding globulin. عشان لو كان عندها total, the bound form is high, you will differentiate between this condition and having, as opposed to having a lot of free and active sex hormone that is circulating in the blood, or androgens. What is the likely diagnosis? And the basis of the diagnosis is what? إذا سألتكم شنو based on what? In the clinical picture, it's fair enough. You can say clinical picture. You can say the altered LH-FSH ratio and the hyperandrogenism and all the other things, okay? But في biochemical changes that occur, all that make you or direct you into thinking that this is a case of PCOS. And if I do, maybe I want to do some imaging. احنا ساعات بنحب في الطب نسوي imaging. So you could do ultrasound of the ovaries and may see these polycystic features that they talk about. All right? So you can do ultrasound, the clinical picture of hyperandrogen. So typically a lot of hair growth in the body. It's that not fine hair, but dark hair, like men, hair in the face. Again, you're talking about dark hair and the menstrual irregularities. And sometimes they have high prolactin levels and altered LH-FSH ratio. Problem 3. During his routine visit to his doctor, a 58-year-old hypertensive man reported on problems with impotence and decreased libido. He ascribed this to the beta blocker he was taking to control his hypertension, having read the package insert of the drug. Further questioning revealed he was now shaving only once a week, and examination revealed pallor, loss of axillary and pubic hair, and the results of baseline blood tests are shown. So cortisol levels ايش فيها؟ طبيعية؟ الكورتيزول أول واحد. ليش سووا الصبح؟ You expect الصبح يكون عالي ولا قليل؟ عالي. So it is low, morning cortisol. don't forget that cortisol levels follow a diurnal cycle, right? TSH levels, okay. Free T4, slightly low. Testosterone, shvi. LH, shvi. FSH, shvi. Prolactin is low, it's fine. What do you think this patient has? Is it one axis ولا multiple axis affected? إذا multiple axis فاكرة أن وين الcommon thing? It's the pituitary, most likely pan-hypopituitarism, some form of pan-hypopituitarism, right? And all these things, shaving once a week. مثلا he used to shave every day or every other day, now only shaving once a week. You'd think in the معناته testosterone levels are slightly lower. And then there is the impotence, decreased libido, that would come with hypogonadism because his prolactin levels are fine, they're not high. So that couldn't be the reason behind his impotence, right? So it is the low LH, low FSH, low testosterone. So why is it important to state timing of the cortisol testing? You already mentioned that it peaks in the morning, declines during the day, and it reaches the lowest levels around midnight. What are the main biochemical abnormalities? We listed them all. What is the explanation of low cortisol levels? قلنا شنو بعد؟ في احتمال إن what else is low? ACTH, right? إذا كان الأكسس suppressed, what do I like to do? Stimulation test. What do I call the stimulation test? All right. So if you are suspecting a deficiency because of ACTH, you can simply give them ACTH and try to stimulate the axis. And if you cannot rescue the axis, that kind of confirms the, let's say, pituitary failure. All right, so what is the likely diagnosis? Hypogonadotropic hypogonadism. So there's multiple endocrine organs in those axes that I mentioned. أعتقد آخر شيء, okay. So far, so good? You think you understood what kind of test to do, how to exclude, rule out, differentials, interpret? Okay? I'm here if you have any questions. I know we have, the session is scheduled till 11. If you want any questions, I'm here. Thank you. يعطيكم العافية. And I'll see you later in the resource session.